Hello, and welcome to Chagpar MD. I'm Dr. Anise Chagpar. September is Prostate Cancer Awareness Month, and I thought I would try to make everybody a little bit more aware of the leading malignancy affecting men and the second leading cause of cancer-related death in men, which is prostate cancer. Now, last time we talked a little bit about what is prostate cancer, who gets it, what are the risk factors, what are the signs and symptoms. But many of you may be wondering about prostate cancer screening. This is a topic that has been of immense controversy and still gets really confusing. So I thought I would dig into the literature and give you a little bit more information that may help you in your conversations with your doctor about prostate cancer screening. So what do you say? Let's get started. Now, if any of you have read any of the recent guidelines with regards to prostate cancer screening, it won't surprise me if you have this look of confusion. It seems that many societies are all over the map in terms of should you get screening, how should you get screening, when should you get screening. Many of them are really wishy-washy in terms of talk to your doctor about screening, and many of you may be left thinking, what am I really supposed to do? Can somebody please just give me the facts? Well, I thought that at least I would give you an insight into where we are with prostate cancer screening so that you have a little bit of data when you go to talk to your doctor. Now, if you haven't already watched the previous video on prostate cancer and what you need to know, who gets prostate cancer, what are the risk factors, I highly recommend that you watch it. And I will leave you a link for that video right here and in the description box below. One of the things that we talked about in that video was the fact that prostate cancer is incredibly common. It's the most common cancer occurring in men and will affect close to 200,000 men this year. It also is the second leading cause of cancer-related deaths, with over 33,000 men dying of prostate cancer this year. Now, the good news is that the majority of these cancers are found at an early stage when it is local or regional in terms of its extent. And in these men, the 5-year survival rate is about 90%. When prostate cancer spreads beyond the prostate, so it starts going to bone and bowel and liver and brain and so on, then you start looking at a 5-year distant disease survival rate of 31%. But because most prostate cancer occurs at an earlier stage, if we look at the 10-year survival rate for all stages combined, it's still pretty good at 98%. But how can we pick it up early? Well, some people will say, what are the signs and symptoms of prostate cancer? Certainly being aware of these signs and symptoms and seeking medical attention is one way to certainly be vigilant about getting checked and finding disease early. So if you have these symptoms, frequent urination, having a weak or interrupted urine flow, needing to strain to empty your bladder, getting up at night, finding blood in the urine or the seminal fluid, having a new onset of erectile dysfunction or pain or burning, those can all be signs and symptoms of localized disease. And certainly, if you start having these symptoms, bone pain, swelling in your legs or feet, unexplained weight loss, fatigue, changes in bowel habit, you want to be really concerned and seek medical attention because these can be the first signs and symptoms of metastatic disease. But for many men, you really want to find prostate cancer before you have any of these signs and symptoms. And that's really where screening comes in. So people talk about prevention. Well, let's talk a little bit about prevention. When we talk about prevention, we're really talking about two different things. Primary prevention is reducing exposure to a risk factor, thereby reducing ever getting the disease to begin with. Secondary prevention is also called screening. Now, secondary prevention doesn't prevent you from getting the disease. Nope, It's just intended to find cancer in asymptomatic people early. So it doesn't prevent you from getting disease, it prevents death from disease, or at least that is the intent. So getting screened does not prevent you from getting cancer. Indeed, it may find cancer early. The idea is that if we find it early, can we actually prevent you from dying of it? And this is where the whole concept of risk and benefit comes in. So, when we think about the benefit of screening, the idea is that finding it early should result in a survival benefit. But it always has to be counterbalanced with all of the risks. So, what are those risks? Well, false positive results. So, if the test tells you that you have cancer when you really don't, that can be a problem. Overdiagnosis, when the test finds a cancer, but that cancer is so slow growing and so indolent that it would have never caused you any problems, even if you didn't know about it. And then you go and you have it diagnosed and treated, you're doing all of that for naught. So that's again another risk. There are risks associated with biopsy and side effects of treatment. And so you really need to balance all of these things. So, how does that break down in terms of prostate cancer? Well, let's look at the benefits first. When we talk about prostate cancer screening, many people talk about PSA, which is a blood test. This blood test looks for something called prostate specific antigen. It's a particular molecule that is found in prostate cancers. And if we find it, you may be able to prevent 1.3 deaths from prostate cancer over 13 years if you screen 1,000 men. Okay. And you may be able to prevent 3 cases of metastatic prostate cancer per 1,000 men screened. Remember, metastatic prostate cancer is when it's spread to other organs, and when that 5-year survival rate is only 31%. Now, the interesting thing is that the studies have found that screening for PSA really had no reduction in all-cause mortality. So what does that mean? It may reduce your risk of dying of prostate cancer, but it doesn't reduce your risk of dying, period. Nor does it extend your life expectancy because remember, the majority of men who get prostate cancer do so later in life when there are competing causes of death. So even if you find your prostate cancer early, and you may reduce your chances of dying from prostate cancer, you still may die from other things at the same rate. The other thing that many of the studies have looked at is whether we can subset out the benefits. So, can this test be particularly helpful in those men who are at increased risk? And you remember from our last video that we said that this was particularly for African American men, men with a family history. And really, the data have found that there is no evidence that we can really subset out and find a benefit in one subset or another. Also, we can't really find enough evidence to evaluate that risk benefit ratio in screening men under the age of 55. So, all of the data that we're going to talk about today is really looking at men who are at least 55 years of age or older. Now, one thing that has been found is that there's no benefit for prostate cancer mortality in terms of screening men 70 years of age or older, regardless of the subtype. So, whether they are Caucasian or African American, whether they have a family history or not, there doesn't seem to be any benefit in screening men over the age of 70. So, let's look at the risks. If we take 100 men and we do PSA screening, we find that about 24 will test positive. Okay, but if we then say, how many of those men actually had cancer? We find that only 10 of them did. So that means that these other 14 men had a false positive result. they tested positive based on their PSA, but they really didn't have a biopsy-proven diagnosis of cancer. Now, if we look at the 10 men who did have a biopsy diagnosis of cancer, well, only 2 to 5 of them would have a diagnosis that really would never have changed their outcome. So these are men who had really indolent disease, and their prostate cancer would not have affected their longevity. So this is overdiagnosis in that 2 to 5 men, so 20 to 50%. So then we say, okay, all of those men, though, who had a biopsy proven diagnosis of cancer are going to get treatment, or at least 80% of them will opt for treatment. You'll note that this includes some of the men who had an overdiagnosis, who really didn't need treatment at all. And what are the effects of that treatment? Well, some of these men, so about 5 of these 8, will end up with erectile dysfunction. 2 of these men will end up with urinary incontinence as a result of the treatment. So then the question is it worth the risk? So in the main, when people have looked at this, they've said, well, those false positives plus the overdiagnosis, plus getting a biopsy and the sequelae of that and the side effects of treatment may outweigh the benefits. And so prior to the most recent USPSTF guideline update, their recommendations were really against PSA testing. But this has changed in the most recent guidelines. And now the U.S. Preventative Services Task Force has moved that to a C recommendation from a D recommendation. And so what they recommend is that men between the ages of 55 and 70 should discuss this with their doctor. So why did they make the change? The data have remained the same. Well, the answer is really that there is a slight mortality benefit. Remember, we talked about 1.3 men can have a reduction in prostate-specific mortality per 1,000 men screened. 3 men can avoid death from metastatic prostate disease per 1,000 men screened. So there is some benefit in terms of prostate-specific mortality. But perhaps more importantly, there is this concept that maybe now there's a shift in terms of what men are doing. So maybe not 80% of the men who are diagnosed with prostate cancer will actually go through treatment and therefore have the surgery or the radiation that causes the erectile dysfunction and the urinary incontinence. If they are happy to simply have surveillance with PSA, knowing that they still have their cancer, but not choosing to have it treated, well, then potentially you can lower some of those risks associated with treatment. There remains, however, a D recommendation for men older than age 70, simply because the benefit doesn't seem to be there in terms of reducing mortality. So what about digital rectal exam, which used to be recommended a long time ago? This really is not recommended as a screening modality for prostate cancer, simply because there isn't really evidence of a benefit to digital rectal exam for this indication. Now, your doctor may still do a rectal exam. Why? Because they may want to evaluate your prostate for benign prostatic hypertrophy. They may want to evaluate your rectum for rectal polyps or cancers. There are a whole variety of reasons why somebody might do a digital rectal exam, but in terms of prostate cancer screening, it doesn't seem to give much benefit. Well, these are the recommendations of the U.S. Services Preventative Task Force. But what do other societies say? Well, the American Academy of Family Practitioners have still kept with the old guidelines that the USPSTF had from before, which is really not to recommend PSA screening. Again, because of those risks of overdiagnosis and treatment. The American Urologic Association, however, really is much more liberal. They say to discuss this with your doctor if you have a life expectancy of more than 10 to 15 years. Now, in order to reduce the risks associated with screening, they recommend that that interval of screening should be more than 2 years. And in order to kind of understand that there are some men who are at higher risk, like men who are African American or those with a family history, even though the USPSTF says that we don't have adequate data and evidence to support screening in that population, the AUA says because we know that those men are at increased risk, you may want to consider screening them earlier. What does the American Cancer Society say? Well, the American Cancer Society says that people should discuss it with their doctor and recommends that if you're at average risk and you're expected to live more than 10 years, you should start having that discussion at the age of 50. If you are African American and or have a first-degree family relative who was diagnosed with prostate cancer at an early age, less than 65, you might want to start having that conversation even earlier, at the age of 45. And if you're at even higher risk, you've got more than one first-degree relative who has been diagnosed at an early age, you may want to have that discussion even earlier still, at the age of 40. So there you have it. All kinds of recommendations from different organizations based on the same data, but just different interpretations. So what is my advice? My advice is to really understand yourself and your risk. Have a conversation with your doctor, but really weigh for yourself the risks and benefits. Are you the type of person who would be happy enough if you're found to have a high PSA and have a biopsy of prostate cancer, not necessarily having it treated if it was of low grade and low stage and could be followed with PSA? Are you the type of person who will really worry about your prostate cancer risk and wants more information? Are you the type of person who is very healthy and you really want to be on top of your screening and know whether or not you have prostate cancer so that you can do something about it? Or are you the kind of person who says, you know what, if I have a prostate cancer, but it's going to be indolent and slow growing, I'm not going to do anything about it anyways? I think that these are really personal decisions that you need to make. And as you can see, the data are the same, but the interpretation of this is all over the map. I think you should really have conversations with your doctor, be open and honest, and know what the data say so that you can be an informed patient. I hope that this has been helpful for you, and I hope it has at least slightly lessened some of the confusion around prostate cancer screening. If it has been helpful, please like and share it. Please do subscribe. Leave me a comment in the box below. Let me know what other topics you want covered. I hope that this has been helpful for you, and I look forward to bringing you more evidence-based health and wellness topics. Until next time, this is Dr. Anise Chagpar wishing you all a safe and healthy week.